So good afternoon, welcome everybody to the monthly improvement forum. For those of you who haven't joined us before, my name is Maria Riley. I am Associate Director of Strategy and Improvement for the Trust and have the pleasure of leading the Academy. If we just click forward to the agenda, please, Carlo. So we'll follow the usual format and look at a spotlight on a number of improvements happening across the Trust. So today we've got Rebecca and Dawn talking as to about the Lewis Foundation and the support that we've had. And then Anthony and Luke from the Royal Academy team will talk about patient-initiated follow-up. Stacey will talk about the work that she's been doing facilitating improvement, but also the introduction to improvement, give a bit of detail on that course. I'll talk about the programs, and then we'll finish with sharing and celebrating success. And if there are any things that people have been working on that you want to highlight and raise within that section, please have a think during the session, and feel free to raise those in that last session. So if we get started, and Rebecca and Dawn, would you take us through the Lewis Foundation? Thank you.
Yeah. Hi, I'm Rebecca, Haematology support worker. And I'm Dawn Warrington, Macmillan Information and Support Lead, and we're just going to give you a little insight into what the Lewis Foundation packs are. Next slide, please. So part of my role as a support worker is to complete holistic needs assessments on all new diagnoses, relapsed, change of treatments and end of treatments. During this time, I noticed how understandably anxious our patients were about starting chemotherapy treatments and wanted to try and find something to break their anxieties. This is when I came up with the idea of giving all new haematology chemotherapy patients a goodie bag. I very quickly realised that this needed to be all tumour sites and not just haematology patients. I started to contact organisations for donations and had some really lovely gifts given to us, which I've been able to hand out to patients. However, I realised that this was going to be quite a difficult task to provide continuity. Myself, Dawn and Lynn, a sister on the chemotherapy unit, had several meetings to discuss the content of the packs and costings and see whether this would really be achievable year on year through donations and potentially charitable funding. We realised the cost implication would be quite large and started to think of other ways that we might be able to make this possible. Dawn was networking with some other Macmillan support centres when she noticed a post on social media about the Lewis Foundation. Next slide, please. So the Lewis Foundation was formed in 2016 by Lorraine and Lee Lewis after Lee's mum was diagnosed with a haematological cancer and was admitted from clinic onto the ward one day and literally had nothing with her. So that's how the Lewis Foundation came to life. It initially started with 80 packs a month in one hospital, and now they're giving 2,500 gifts a month in 14 hospitals. Each pack costs approximately £3.60. In 2020, they gave a staggering 21,167 packs out. They've got 50 volunteers that help pack each gift pack, and they are packed to proper COVID regulations. And in each pack as well, there's a special handwritten note with positive thoughts, which the patients are really saying has really helped. We started receiving our packs in January. Next slide, please. When we had our first delivery of packs, I can honestly say myself and Dawn were absolutely blown away by the amount of packs that were delivered and the choice that we'll be able to offer our patients. There's 29 different packs in total, ranging from ladies and gentlemen's overnight packs, which is so useful if any patients get admitted from a clinic environment, to mini games, audio books, dry skin packs. And packs are all available to all adult cancer patients, inpatient and outpatient. Next slide, please. Our initial idea for the welcome pack was to combine 3 of the packs together, and we chose a dry skin pack, a care pack and a puzzle pack for all new starters of chemotherapy. We realised that there was some duplication and a lot of package being wasted, and also a cost implication to the foundation. So we worked together with the Lewis Foundation to incorporate 3 packs into one, and this is when our welcome pack was born and will be given to all new starters of chemotherapy. Patients also attending for subsequent visits can have any of the other packs at any time. The feedback that we've had from patients has just been amazing. There's a couple of examples on the slide. I also recently gave a pack, a care pack, to a lady who was having her chemotherapy as an inpatient. She told me that she wouldn't have been able to get through this admission without it. It's very lovely. It's got earplugs and an eye mask. So she said it actually enabled her to get a proper night's sleep and the rest that she needed to get through her admission. Next slide, please. So what we really need to do is to spread the word about these amazing packs. Because we don't actually have a designated cancer ward, it's difficult to always identify where the patients are and who may benefit from the packs. All our cancer nurse specialists are fully aware and do take packs up onto the ward. We've got a post going out today on the Royal Roundup to try and just spread the word. We do have a cancer information centre newsletter that goes out to all the cancer clinicians and teams across the trust and also primary care. So when that went out last week, there was an article in there about the Lewis Foundation packs. And also we've recently launched our information centre app, and there's a section on there on the professional section trying to raise awareness. But what we really want to do is, from A&E to any of the wards, if any adult cancer patient is anywhere, we'll happily take a pack and just give us a ring, contact the centre, and we'll do what we can. Thank you very much. Have we got any questions?
Wow, that's amazing. That's such a really great news story and such a patient focused approach. It's really well done, both of you, for bringing that, and also our thanks to the Lewis Foundation for the brilliant work that they're doing. So help that you need would be to, how do you spread this message and how do we ensure that, you know, all patients get access to this? So my first thought that I was going to go to was Stacey, for your thoughts. Have you got any thoughts, Stacey, on how we can support?
I think that was absolutely amazing, and of course my head starts thinking, well, that's brilliant for that type of patients, and then I start thinking about what about everybody else, because if I was laid in a bed next to somebody that had got that, I'd want one. So I think you've probably set the cat amongst the pigeons really with that. It's brilliant. But I think from getting the word out, maybe matrons meetings is always a good place, because they might just be able to identify that patient. There's always those that just slip through the net with the specialist nurses. So I always think that that's always a good starting point. Obviously there's the screensavers on the computer screens, but nurses aren't always good at really paying a lot of attention to them. There's nothing better than sort of word of mouth, and I'm sure that once a few patients on the ward have got them, that the nurses will soon latch on to the idea. I'm convinced of it. Okay. But that was brilliant, Dawn. Thank you.
Thank you.
Thanks, Stacey. Are there any more questions or thoughts? Luke, did you want to come in?
Yeah, again, absolutely brilliant piece of work. Just expanding what Stacey mentioned, I wondered about some of the allied health professionals as well. So particularly thinking about if any occupational therapy might see any patients on the ward or something like that. They often have a holistic approach. They might be very keen on using these packs, so it could be that you speak to them.
Mm-hmm. Yeah. What would be the best arena to speak to them then, Luke?
So I would, the people who they all have individual meetings, but I'm wondering whether they do have a heads of therapy meeting or any of the team meetings within Suite 5. Yeah. It might be that you go to there. But yeah, I guess the head of occupational therapy is Rebecca Sheldon. I'm just thinking because it's related to more holistic care, they might look at that.
Okay, thank you.
Thanks, Luke. Richard, did you want to come in?
I was just going to suggest that you came down to one of the acute medicine huddles at 11 o'clock, have a chat with Stacey Clark, because getting them right at the front door would be a great place to start, isn't it? Certainly for the medical patients. Sounds like a good idea.
Okay, thank you.
Thanks, Richard. Pamela?
Yes, it was just say I think it's absolutely brilliant, and I think the content would be really, really appreciated, but also just from a patient perspective, I'd be thrilled that people have been so thoughtful to actually think about it. So in terms of how it would impact their experience and their journey within that service, that would really help them to feel supported as well. So I guess it's a pronged benefit for them.
Thank you.
Thanks, Pamela. So we've got a couple of ideas there. If you need any more support in terms of linking with who's the right person or how you make any of this happen, Pamela, Cherie, myself, you can just get in touch, Dawn, and I'll make sure we put you in contact with the right people. But again, my huge thanks. It's a brilliant piece of work and such a fabulous thing for the patients. So thank you.
Thank you very much.
Thanks, both. So you're going to have to follow that, Anthony and Luke, with patient-initiated follow-up. Sorry, Anita, you put your hands up. A bit dry. Anita, did you want to come in?
Yes, hi there, everyone. That was really great what you're doing there. I'm sure it will really benefit everybody. I'm a midwife and I'm involved in smoking cessation. I'm just looking at ways to make improvements. And one thing that I've been looking at is little quick kits for women. So when they come to the hospital, we can give them things like a Lipsol or some sugar-free mints, anything to like put in the mouth or use the hands, or little hair bobbles. I'm sort of a little bit at a loss as to how I'd go about getting the funding with that. I need to speak to smoking cessation, but I'm just interested for the people that have done this, is sort of where, when you say charitable funds, whereabouts did you get the funding for these things from, just to give me a bit of an idea of where I might sort of start getting some funding for this kind of thing. It wouldn't be for every, I mean, our smoking rate is about 13.5%, so we'd be looking at sort of about 400 women a year. So it wouldn't be for every maternity patient, but it would be just for a, 13.5% of them really. And that's something that I've sort of been thinking of for a while and been sort of had other and more important things to do. Well, I say not important, this is important, but other things have had to look at guidelines and things. So this is something what I would really like to be able to give out when women come for the dating scan if they are still smoking.
Did you want to come back on that, Dawn and Rebecca, about, so I presume on this one it's all funded through the charity, is that correct?
It is, yeah. So initially when we did look at obviously charitable funding through the Chesterfield Hospital charity, we just realised that it wasn't going to be sustainable. And then it was just obviously, from spotting one of the packs in another hospital, that's obviously when we amazingly came across the Lewis Foundation. But I suppose for yourself, it would be, it might be something that the charity here could certainly help you with. So there's just a form that you would fill in, and then discussion, and then they would agree or disagree, I suppose. Is that right, Maria?
Right.
I think we can absolutely take that through our own charity. And Stacey, I can see you've got your hands up because you've got experience of doing exactly that, haven't you?
Yeah, I was just going to say, if you wanted to drop me a line outside of this meeting, we can meet up and I can help support you with that.
Oh, that would be great. Is that Stacey?
It is, yeah.
Stacey. Lovely. Thank you so much, Stacey. That would be wonderful. Thank you very much.
No problem.
Thanks, Anita. So we'll get in touch and we'll hope to hear from you when you've got this initiated yourself, and this is also happening for maternity patients. So thank you.
Thank you.
Patient-initiated follow-up then, Anthony and Luke.
Hello, everybody. So like Maria said, I just want to say as well, I think that's fantastic. I think the packs are absolutely amazing. And yeah, how do we then follow on from that, trying to pretend that we're patient-centred when you're doing something so amazing? So well done, guys. So I'm Anthony Kenny. I'm the PMO for the Trust, and during the first wave of COVID and to now, was tasked with getting patient-initiated follow-up instilled within the Trust. And I'll let Luke introduce himself.
Hello, yes. So I'm Luke Jenkinson, an improvement program lead for outpatients. So again, like Anthony said, this is kind of stretched from over the past year, really. So it's a bit of a whistle-stop tour about what we've done.
So next slide, please. So what we tried to do is following the first wave of COVID-19, there was a restoration and recovery plan that was set out by NHS England, and patient-initiated follow-up was one of the mainstays within that plan. So quite early on, Chesterfield recognised the value of what this would offer to our services, especially in outpatients. And the idea of patient-initiated follow-up, or PIFU, is that you have patients that we traditionally would have always brought back. We have regular updates with them. We have these just in case appointments, etc., etc. And the idea is that rather than us dictating to the patient when we bring them back or whether they need to come back, we allow the patient some autonomy in that decision-making process, and that we give them the option, clearly defined. It could be 3, 6 or 12 months that they can come back to us. They can use that opportunity if they feel they still need us to come back to us. And previously in our trust, we offered something called open appointments, and all PIFU did was take open appointments where patients felt a little bit lost in the pathway and regulate that pathway and make it auditable for us, so we didn't lose patients, and a little bit safer. Next slide, please. So in terms of patient-initiated follow-up, Luke and I have been really heavily involved in the Joined Up Care Derbyshire journey, and not just with PIFU, but with a lot of things that are based in outpatients. But one of the nice things about PIFU in terms of what we've created is that if you go for a patient-initiated follow-up at Chesterfield Royal, it means exactly the same as Derbyshire or DCHS or UHDB, and that's actually one of the main things that we've been really successful in, is that the language is exactly the same for patient-initiated follow-up. So for our patients, they know what it means, and importantly, we included all GPs in a lot of this, well, in all of this discussion, so the GPs know what it is. So we had a real emphasis on empowering the patients, that it meant the same thing, and when they asked the question of the GPs or any clinician, whether they were working at Derby or at Chesterfield, is exactly the same. And actually the PIFU programme has actually supported, because we've created like a universal dashboard that Luke will talk about, that we've actually shown that we can capture data as a region, as an ICS in this Joined Up Care Derbyshire. So we've really been forward thinking in that and created some really good dashboards that have led to other dashboards being created. Next slide, please. So our initial aim, we were quite conservative with our initial aim. And I remember I met with Maria, and it was, what do we think we can make? What can we do with this? And I conservatively, we were talking a couple of thousand, and I said, actually, let's just do 1,000. And Maria agreed that actually, because we were focusing on virtual, so that was video and telephone, to restore services to 100% and create some capacity, that PIFU roughly we could do about 1,000 patients by April 2021, so at the end of the financial reporting year. So from July to April, 1,000 patients. Next slide, please. As part of doing that, we had lots of issues with working out how our patient administration system works. So Medway, so working out how we could manipulate Medway to get patients on a PIFU pathway and make sure we could take measures out. So we're trying to do improvement, measure focused. So what is the return? You know, what is the benefit to the trust? What is the benefit to the patient? What is the value added to the pathway or the system? And we set that quite clearly at the start. As I've said there's a clear language of PIFU. PIFU was set as a reporting, as an operational important reporting element. So we had our outpatient group, and we're asking people, are you offering PIFU? You know, what's it do, etc., etc. We say engagement with patient populations, that's more national, but regionally. We've now started our own survey, so all the patients that have been placed on PIFU will get some form of communication from us and ask for feedback to make sure that we are targeting the right people at the right time and they're being treated in the right place. Some interesting things have come out of the data, so we've started to recognise that PIFU is used, I think, less for patients from an ethnic minority, so from a BAME background. So we're going to now use some of the patient-focused evidence base to look into that and try and dig down a bit deeper on that. And we did lots of stakeholder analysis, SPC charts. Luke and I created lots and lots of detailed metrics to show the success of this. And we also had to do the EQIA, which only recently went to the QDG board. It's basically our quality impact assessment to show what this does for the system or for the patients. We had to completely change the admin process to how patients were booked and removed from the system, like discharged, and an improved and different patient pathway to than what had been before. So next slide, please. So initially we did, all recce slips were changed, and all the reconciliation slips just had PIFU added on, and it was 3, 6 or 12 months with no push from us. It was just that we changed that onto the recce slip and gave some very basic information of what PIFU was. We centralised the PIFU pathway through the centre of the trust. We stopped people being able to make changes and independent changes like CAOs and receptionists. We said it must all go through the booking team and be one centralised pathway. And initially, we didn't focus on any area. We just opened it up and said, is this useful to you? This is the basic guidelines. We created some resources and said, use at your will, because we thought that would be the best way to see how to kind of test where the interest was. Subsequent recommendations from that initial PDSA is must be data driven, required a reporting dashboard that's insightful and useful, always clinical decision to place someone on PIFU. That was the ultimate thing, that a clinician decided if that patient was correct or not. It would never be decided by anyone but that clinician and the patient together, and that the PIFU must mean the same for patients across Derbyshire. Next slide, please. So obviously this is going into a lot of detail, and I do recognise we've got a finite amount of time, but what we managed to do with our Medway is that NHS E&I set very strict restrictions on what PIFU must mean and what it must do. And thankfully, the way we set up our PIFU, we can meet all of those requirements that are set out by NHS E&I. So we've opened up access to the Elective Recovery Fund, which is quite a big achievement. We've created those streams, and we also generated a letter, like a discharge letter, that went to the patient but also went to the GP. So it was empowering of the GP but empowering of the patient. So not only would they have that discussion with the patient, the clinician, they would also get a follow-up letter. And we've also encouraged people to set up templates on CETO for a PIFU dictation, so the CEOs can choose that letter for the dictation. It has another paragraph on PIFU on there, so we're trying to give as much information as empowering as possible to patients. System 1 has been a bit of a different system because it's another PAS that we use in the trust, but at the moment it's a bit of a paper heavy system that we're counting the number of letters that have been sent to show how many people are on PIFU. However, this is in the process of, from working with our regional partners that use System 1, to actually find a different way to report in a more auditable way that's focused from the informatics team centrally. Next slide, please. So I'm going to let Luke talk about the data-led improvement. After you, Luke.
Thank you. So yes, I get all the exciting stuff now, the data. As Anthony said, in order to lead this improvement, we wanted to make sure that we've got kind of continual evidence of where it's working, where it isn't working, where we're being successful and where we need to kind of target efforts. So to do that, we created a Joined Up Care Derbyshire patient-initiated follow-up dashboard, and that was big thanks to the informatics team and Claire Carson, because we really did pester for that, but it's proven to be so valuable now. It allows us to compare directly with national benchmarking data, so we can see where we are doing well, where we could do better. And at the time, I'm not sure whether this is still right or not, but we thought we're the only region in England and Wales with this joined up data set for PIFU.
We are, Luke. We still are.
Yeah. So that's really good that we're still there, kind of leading the way. Like I said, it let us target areas for expansion, and then also see where it's worked and where we can share our learning with other trusts. And again, what it did do is, by creating a dashboard, it's meant that we've all got to measure the same thing in every service. So it's helped us standardise what PIFU means. So if you've come through kind of the training and improvement in the Improvement Academy, we're very much focused on defining exactly what we measure. And by creating a dashboard, that made us do that. Next slide, please. So if you look at kind of, it will focus on the picture on the graphs and the picture on this. So this is outpatients and patient initiated follow-up measure for everywhere in Chesterfield. So what this is looking at is on the top left box, we can see the percentage of PIFU outcomes per month, and that obviously hopefully that's growing, and I think the more up-to-date data shows quite a large increase in the recent data. At the bottom, we've got the number of PIFU outcomes per week. And again, this is for the whole organisation, and obviously we've got more data since we created these slides. But one of the balancing measures that we wanted to make sure that we captured was the waiting time. So this was the time if someone reactivated an appointment. So if they wanted to access our service again, how long does it take to access an appointment? What we didn't want to happen was implement patients-initiated follow-up, and then it take longer to get an appointment through this process rather than going through the normal route of a GP. So that's something we are measuring as well. Next slide, please. One other thing I guess to highlight is obviously we've worked as a joined up care Derbyshire system, but what we wanted to do is make sure the process was the same as well. So here, this was our process that we created at Chesterfield Royal, and you can see how simple it really is. So it's literally just the clinician and the patient decide whether PIFU is appropriate, and they're either put on it or not. You can see the timeframes that we originally planned on here. So 1 month, 3 month, 6 month and 12 month. And at the minute we're in the process of changing that slightly. So another example of a PDSA cycle where we are now adding a 9 month in if possible. We need to work out whether this can be done with data and informatics and appointment systems and things like that. But that's where we're going to try and tweak to meet the needs of certain services. Next slide, please. So just to mention as well, what we also did, that was our process map. We made sure it linked directly with Derby's as well. So we've cut it out of this slide deck today just because of time, but we got their process map and made sure we work together to make sure it means the same thing. So success so far, we've reduced waiting lists in certain specialties from 5 weeks to 1 week, and I think orthopedics is a really good example of that. Where myself, when I was working clinically, I could get a patient into a slot within days, really, in orthopedic outpatients, which was just fantastic and worked perfectly for the patient. And again, that shows that we've improved responsiveness for our services. We've taken pressure from our primary care partners, or at least we've tried to. We understand that everyone's under a lot of strain at the minute in the system. But by coming directly to us through a patient-initiated follow-up, it means that they will hopefully reducing some of the time needed for GPs to reassess. As a trust, we're aiming for 5% of all of our outpatient appointments being outcomed as patient-initiated follow-up. And that's what we're aiming towards, but some specialties we're aiming for more. So like Anthony said, we've targeted certain specialties and we're aiming for 10% in those particular specialties. Next slide, please. So here, I'll not read them all out, but you can kind of see that we've spread quite widely across the organisation. And if you're in a service that we've not got round to, or you're really wanting to do it, then please tell us, because we can come and work with you. It's probably worth saying that on some of these services here, they're not finished. So, for example, diabetes, we've not truly embedded PIFU yet, but that's one of the areas where we're working on at the minute. So yes, if you're interested, please let us know and we'll come and speak to you. Next slide, please. So just moving forwards, one of the things which we do want to work on is having closer links with the cancer services. So in cancer, they use patient stratified follow-up. And what we truly want to make sure is, we want to make sure that we're measuring the same kind of differences in what we're measuring. So we don't want to be measuring things twice. So we're going to work with PAM just to make sure, so PAM rumbling cancer, just to make sure we are getting the measurements right, but also capturing everything that we're doing. So if we need to capture the patient stratified follow-up as well. Diagnostic-led PIFU. So this is where we can hopefully get applications and kind of different systems in place to automatically generate the follow-up when it's clinically relevant. So an example, if people hit certain pain scores or certain symptoms, then that could trigger the follow-up. As a joined up care Derbyshire region, we want to be the nationwide leader in PIFU as a percentage of all our outpatient appointments, and that's something me and Anthony keep kind of pushing for and striving for, and probably frustrating some people with, because we keep talking about it. But again, by doing that, then it allows us to support other regions, which we have now got evidence of. People are coming to us and asking for support in implementing this in their areas. Next slide, please. I don't know if there we are. Yeah, that's it. So any questions?
Thank you both. We're always ambitious, aren't we, to be the best, and we have really done really well for a very small DGH in how we've taken this forwards and how we've gone about it on a truly collaborative system approach. The thing I just wanted to mention was Luke and I did a Derbyshire dialogue session, which is a session that Joined Up Care Derbyshire do with the public, and we had around 100 members of the public, and we talked to them about the range of improvement interventions that we're putting in through outpatients, and patient-initiated follow-up was one of them. And it was really great to get feedback from them that all the things that they were kind of worried about, we were addressing. So they were concerned about the consultation and patients being really clear about what pathway they were being put on and how they would be-accessed, and we were able to give them assurance about that. They talked around GPs understanding the process and having their GP communications, and we've been working with primary care right from the start on making sure that we set this process up in the right way, and all of primary care understand what this means as well. And then they talked about language, and it was very important to them that patient-initiated follow-up meant one thing, whether they were having an appointment with us or at UHDB or at DCHS. And we were able to reassure them on that we were working collaboratively. And then the final thing was about time to re-access. So being able to answer that question and say we'd already got measures in place to ensure that we were monitoring and that patients weren't waiting a long time to re-access the service. So it was really reassuring to do that session and be able to reassure any concerns that came from our public and our patients that we'd tried to address those, or we were working on those. And then more questions for Luke or Anthony? No, thank you very much both. We'll be here in a year's time hearing about how we are #1 on model health system for patient-initiated follow-up. Thanks both. Shall we move on? So Stacey, you're going to talk to us about the work on bringing improvement to life and the one-day introduction to improvement.
So I'm going to talk to you mainly about the introduction to improvement, and really just to sort of sum up where we are so far. So next slide, Carly. So we reintroduced the course in March. Initially, we had 7 staff members that attended. It was a virtual session which were facilitated through Microsoft Teams. Some of the projects that people were interested in looking at was improving the audit plans and management reports on DATEX, and looking into the diabetes pathways. So what did we do? So what we do with the one day, well, half a day improvement now is we give you bite-sized chunks of how to kickstart your project. We give you an interactive workbook and links and tools to support your project. So we actually take the project that you'd got in mind and we start working through it step by step to help you launch the start of your project. We spend a lot of time on the practical application. We support beyond the morning. So the morning is just for you to get to grips with where to start and what to do. But beyond that, we ensure that your project keeps momentum. We keep in touch. I email you a week after that you've attended to see how you're getting on and offer further support. Also at 30, 60 and 90 days. And there's always, if anyone needs any help, you've got all the details that you need to get in touch so we can help you keep your project moving. We also log all of the project ideas, so we can signpost others to support. So it's still in its infancy, but there's going to be at some point, I'm sure, several people that want to all achieve the same thing. And that puts us in the ideal place to link you all together so we can do some joined up, even cross-divisional working. So that's our ultimate goal. Next slide. So what have we done since we started in March? So we've used our methodology that we teach, and we've PDSA'd the actual content of the course that we provide. So we've looked at all of the feedback that everybody's given us, all of the tips. What would you want? What do you think there's too much of? Do you think there's any more? And we've tweaked as we've gone along. As COVID guidance is lifted, we've return to doing the face-to-face, which is much better. People get to interact with each other, listen to each other's projects, and we find that that's really, really working well now. And today we've had 20 members of staff to attend. We've got 12 more booked on for June, and very few spaces, I believe, for the July session. Next slide, Carly. And as a result of one of the sessions, we have, so we've met with the Eye Centre. We've generated some absolutely fantastic staff-led change ideas, and actually we've helped bring a lot of them to life. So a lot of the frustrations that they were feeling, we've sort of got it out there. There were some really quick wins that we could do. Something as simple as a question was asked is, why haven't we got a second phone? So we helped with that. There's some longer term goals of space where they can have a break, but we've managed to get them some extra picnic tables ordered. So during the summer months, they've got somewhere else to sit outside. And longer term, we're actually looking at revitalising a courtyard area to make it into a nice area that they can go and sit and have their breaks. And we've also set some longer term goals. But I think more importantly, the staff have really been empowered to run with their ideas, which is absolutely brilliant to see. So just a little snapshot of some of the feedback that we've received from the one-day improvement. So it's evaluating quite well, really. And each time we get that feedback, we really do look at it, and we really do try and make improvements of it. So we'll keep an eye on what happens moving forward. Any questions?
Thanks, Stacey. It's great that we've tested, we've adapted, we've changed it again, haven't we? And we'll continue to do that for the future. So get in touch with us if individually you're interested in that session, or you'd like to attend that session as a team. That's also something that we can offer to kind of work through a project on a team basis. And also, if you're interested in that kind of team engagement, creative thinking, you know, what are the quick win areas, please get in touch with us, or with Stacey directly, or with any of us through the improvement inbox team. Thanks, Stacey.
Thank you.
Move forwards, please, Carly. Stacey, are you staying with us to talk about the newsletter, or? No? Okay, I'll do the newsletter. So
Carly's nodding at me to say, yes, you are.
I'll do it. So we've got the newsletter, which hopefully some of you will have already seen. So this can be small things, big things, you know, any kind of improvement that you're proud of, any change, any ideas that you've been able to implement, please get in touch, and we'll put that into the newsletter and share it far and wide across the organisation. So please get in touch with us. We do that on a monthly basis, and like I say, you might think it's too small, but it really won't be. It's really about connecting people up with ideas. We can use that to kind of share. There's a couple in there. I can see one from Carla, who's an ED receptionist, who had an idea around the change in folders, which Stacey was able to support with. Yeah, so get in touch and we will share your improvement via the newsletter. Next, thanks, Carly. My screen's flicking around a little. So in terms of the improvement training programme, so Stacey's spoken to you about the introduction to improvement. One of the things that we've been running is the quality service improvement and redesign course as well, the QSA programme as it's known. And we started that right back when we started the academy 2 years ago. That's a 6-day programme, and it gives you a formal practitioner qualification. And we unfortunately had to stand that down over COVID, but we've relaunched now. It's in a face-to-face format, similar to what Stacey talked about. The shared learning, the conversations are really important as part of that programme. So we're back in a face-to-face setting, but we are really comfortable and happy with how we can do that in the Innovation Centre. We ask people to work through a project. The course dates are every couple of weeks, and although the programme nationally is a 5-day programme, we add on day 6 here so that we can use that as a forum to share and celebrate success, and also get people who have the practitioner programme up to speed with how they can get involved with improvement going forwards. So the course dates are there going forwards. Please get in touch with us if you're interested in that programme, and we can give you more details, and we can put you in touch with people who've been through the programme as well. It's all taught by people who have been on the national programme and then are accredited to teach it. So all of us who teach it work in the trust, and we've tried to translate some of the national teaching into real life examples of how we've delivered improvement in Chesterfield Royal, how we've delivered and used some of the tools, and how what impact that's had in terms of projects that we've delivered in the trust. Next slide, please, Carly. Introduction to improvement we've already talked about, so I think you can move forwards over that. There are your dates, Stacey. So the dates forward are there. Please get in touch, and like I said, they are the dates that we've got for individuals to book on, but if you had a view that you'd like a team session to work up something particular, get in touch and we can always work with you to develop something bespoke up for you. Next slide, please. So sharing and celebrating our success, we always end with a couple of highlights of just other things that have been happening across the trust. These slides go into the hospital leadership team improvement report on a monthly basis. So we'd love to hear from you if you've got things again that you'd like to share in this section. Thanks, Carly. So our clinical IBD nurse team have set up a Facebook group with an information group for patients diagnosed with IBD, and there's the link there if anyone wants to have a look at it. We're really, really delighted to be restoring volunteer services and welcoming back our Royal Rider drivers, so you'll hopefully see those out and about in the corridors. Next slide, please. Our Royal Primary Care team had a national visit this month. They welcomed Lord Prior and NHS England colleagues to talk about health inequalities in the region, including the Chief Exec of NHSE there. Our Equality, Diversity and Inclusion webinar series is now available on Aspire, and they're going to run once a month. They're highly recommended. I'd definitely recommend that you have a look at those. There are sessions around leading inclusion, being an ally and bringing your whole self to work, which are really great sessions. Next slide, please. Our emergency department team have been producing a series of videos supporting patients with decision making. So that's very much about understanding what the resources are taken when patients arrive here with non-emergencies who really should be better serviced within other services. So they're a great 2 videos with Kay talking there. And also some work around DSFS and Office 2010, which many of us are working on, is now unsupported. So the team are working on a rollout of a bespoke NHS version of Office 365, which is a cloud-based subscription. So that's in the pilot phase at the minute, and they're looking for users willing to test Office 365 and also for volunteer champions who will become subject matter experts. So there's a link there if any of you are interested in getting involved with that pilot. Please let the IT team know. I think that was the next. So we've got a few minutes. Are there? Does anyone want to talk about any other aspects of improvement? Kevin, you've got your hand up.
Yeah, just to say that I've recently participated in CUSA, done up to day 5, and just say that it's a really well delivered programme that gives you lots of building blocks to help you with your project. And it's just to recommend that to anybody here that it is a really good course to go on.
Thank you, Kevin. Actually, while you're on, Kevin, you could talk about, so you've been doing some work, haven't you, around the NGS Macmillan unit and trying to get more cancer services into that clinic. Do you want to just update on where you've got to? Because you've made some really good progress.
Yeah, that's a project that started back in November, as Maria says, to look at what clinics are running in NGS Macmillan with a view to making as many of those cancer related as possible. And I've used some of the tools and tips in the CUSA course to help with that project. So stakeholder participation, driver diagrams, and set up monthly project meetings. And so far, it is a challenge, but we have managed to move 6 cancer clinics into the Macmillan unit, and we're progressing work on looking at moving a few more in. The challenge is that the hospital's fairly full, but we are then looking at clinic utilisation and the most appropriate use. So we are making progress with it.
Thanks, Kevin. I don't like to pick on people, but I can see Cherie's with us, and you've recently had a paper published. Do you want to tell us about that, Cherie?
Yeah, so Dawn's on as well. So it was pre-COVID, and it was all based on a patient who came through one of our cancer pathways and had quite a poor experience with interpreting services. It wasn't actually signers from our side, it was unfortunately Sheffield, but over at Chesterfield. So it led to this lady accessing the Information Support Centre. And on the back of that, what ended up being developed was we realised that actually for the deaf community, you don't realise how difficult it is for them to receive information, and actually how everything is geared up not for people from the deaf community. So based on the back of that, we did a bespoke sort of cancer survivorship course, so based for people who finished treatment really, from across the whole of Derbyshire and even wider. It ran for 3 weeks. Different sessions, sort of things like fatigue, fear of reoccurrence, nutrition and diet. So we covered, and then the final week we're over to the participants really to say what they wanted us to focus that on. So it wasn't without a lot of difficulties, as Dawn will admit, and a lot of organising, but actually the feedback was amazing. And one lady, obviously we couldn't have done it without the signers that supported us, but one lady's feedback was deaf empowerment. That's how she felt after the course, and actually that was the lady that had borne all the idea really, that had had that poor experience. So we've just had it published in Cancer Nursing Practice, and actually we've just done another deaf awareness sort of basic alphabet day the other day that we rolled out to all the cancer teams to take part. So I think we've got plans for how we would go out to some of the existing deaf groups, but obviously then COVID hit, but I think it's something we will pick up. Dawn, do you want to add anything to that?
No, the only thing I would say is that from the workshop we did identify how we could make the patient experience better, particularly when they're booking into reception. So I have emailed I think Trudy and who was the other lady, Cherie?
Vicky Devlin.
Experience, yeah, just to see if there is anything within the hospital, because obviously it's not just isolated in the NGS, I'm sure it's hospital wide, and they sort of did talk about having prompts ready to sort of pick up and show the person that was checking in. So obviously all these things need to be pre-prepared. So I'm sure there's things that we can do to improve the experience for people attending the hospital.
Thanks, Dawn. Brilliant piece of work both. And Stacey, I know you've been working, haven't you, with supporting the deaf community. Did you want to come in?
Yeah. It's just to let you know that we're just waiting for IT, but we've had the go ahead for some apps for iPads, and one of them is almost like a dial-in signer. So you could get one pretty much all of the time at any time if somebody came into hospital and wasn't where. It's called Sign Live. We've also had the go ahead for an app that, whilst we're all wearing masks, it's very difficult for patients that are lip reading, and there's another app that you can speak to that would actually give you subtitles as well. So it's just a case of us waiting for the IT department to actually upload them. The other thing that we've been developing with audiology as well is a deaf awareness grab box, and it's got the amplifier in to help people that you can speak into, so it can make your voice a bit louder, and it's got all sorts of different tips about hearing aids and all the information of where you need to go, how to get interpreters and things like that, all in one place. We're hopefully going to be having one in the equipment library, and we've yet to choose sort of 2 pilot sites as well, just so we can measure its success to see whether we need one for all areas or whether we just need to stock it in the equipment library for people. So there has been a lot of work. COVID has slowed it down, but we were hoping to launch it all together. So we're just waiting for the apps to be sorted, really. That should help.
Thanks, Stacey. So yeah, we've got pieces of work that we can connect together here, which is great, and hopefully we can all align it. Eddie, any support you can give us with getting that app sorted would be much appreciated. Thank you.
No worries.
Can we just add, Marie, I think the deaf awareness training that we had was fantastic. What we had to set up our groups, and I think what we took for granted is we you assume that people who are deaf actually can read the written word, and we were quite surprised that actually that's not something that actually is as common between groups. I think there was just so much learning that some of that deaf awareness could be rolled out sort of trust wide. It was a better quality than anything I'd ever accessed before. It was via Macmillan, but it was actually via a deaf facilitator, and it was really good quality.
Thanks, Cherie. I think we should definitely have a look at that then, see what else we can do internally to replicate that. Stacey, do you want to come back?
Yeah, it's ongoing as well, that is. So we have got a deaf assigner that's willing to sort of come and do it. So that is ongoing as well, because the training that we provide, it's not the best, really user friendly, and we're looking at using some Sims as well to do the training. So that is all ongoing as well.
Thank you, Stacey. Are there any other areas of improvement people would like to share or talk about? No? Well, thank you very much for your time, everyone. Thank you, Rebecca, Dawn, Anthony and Luke and Stacey also. Thank you very much for joining us. Please point colleagues who weren't able to attend to the recording that we will publish online. If you want to present your improvement in a future session, please get in touch with us. If you'd like any other support with improvement work, also get in touch. Any further information about the training, we'd love to hear from you. Thank you very much for joining us, and I hope to see you next month. Take care.
Thank you, everyone.
Thank you. Thank you.
Thank you.